Hi, I'm Dr. Melissa Walton-Shirley, and thank you so much for joining us tonight with the Cardiology Show. I have two very distinguished guests with me this evening, and I'd like to introduce them first. Dr. Cecilia Lind, Chief of Cardiology at the Karolinska University Hospital in Stockholm. So you're at home, aren't you?
Yes,
Absolutely.
definitely.
And then Dr. Clyde Yancey, the past president of the American Heart Association and medical director at Baylor Heart and Vascular Institute in Dallas. Thanks so much for joining us. Welcome.
Happy to be here, Melissa. Thank you.
Thank you.
Happy to be here.
I think we're going to talk today about the focused update on ESC guidelines on device therapy and heart failure, and also we're going to talk a little bit about the SHIFT trial. So if you don't mind, we'll start with SHIFT.
It'd be a great idea to start with SHIFT trial because you know what? Finally, we've got a positive trial in the field of heart failure, admittedly with a number of provisos, but the idea that we've explored a different compound for a different indication and we see real benefit on top of evidence-based medical therapy is at least provocative, if not more so. That is to say, we may have found something that changes the way we practice eventually. We're not there yet, but it's a very provocative study.
What about the debate, though, with the heart rate lowering and beta blockade? You know, usually my habit is when I have a patient with heart failure, I titrate the beta blocker upward until I actually get a rate down in probably the 50s, and the heart rate here was in the 70s, and then they added the study drug. So what about that issue? Do you think that we could have done better with up titration of beta blockers?
So for the benefits of our audience, let's just talk about SHIFT so everybody knows the context of the information. So Ivabradine is an unusual drug that influences pacemaker channels that affect the functionality of the sinus node. In some circles, this channel is called the funny channel. Nevertheless, by modulating the function of the sinus node, it, independent of any other effect, slows heart rate because it reduces sinus node activity. So in a group of patients in sinus rhythm with reduced DF heart failure on evidence-based medical therapy, Ivabradine versus placebo was the tested hypothesis. And the idea was to really focus on a previous observation that patients with a lower heart rate, particularly in the beta blocker era, did better than those with a higher heart rate. Now, was that just a smoke signal from the beta blockers, or was it in fact meaningful and had something to do with outcomes? This study was intended to test that hypothesis to understand the importance of a lower heart rate, and the target was to get the heart rate into the 50s. So that really is, if you will, the overarching principle. Now, Cecilia, I know that you are an electrophysiologist, and so we're kind of dipping into your space by affecting the sinus node, but the beta blocker doses weren't as they should be. That's correct.
No, that's for sure, and that's particularly perhaps interesting in view of that many of the patients were actually in functional class 2, and it doesn't tell exactly how doses were uptitrated, but in my mind you need to see the patients maybe 3 or 4 or many more times before you reach the target dose, and if you can make judgment whether this was done accurately or not, you need to have it better described. But it might also be, like you suggested in the previous discussion, that some patients actually don't respond to beta blockers and maybe should not be given them in the first place.
Or some patients had an exaggerated response and were already becoming hypotensive.
Yeah, that's for sure. And we all train that to achieve the maximal dose that is recommended is clearly related to the degree of left ventricular reverse remodeling, and that's why we were aiming at getting to this target dose. But maybe that's not true on the individual level, and that's perhaps one of the lessons in the SHIFT trial. And then we have an alternative therapy, which is very welcome.
I would agree.
I think in this trial, to be included, you had to have a heart rate above 70 in the first place, so you could not have relative bradycardia. But I think it's always important not just to test at rest, but perhaps while the patient is standing up and during at least modest exercise, because those 3 conditions tell you very much about what kind of heart rate range the patient moves between. And I think the same is true for blood pressure measurements. It's not just enough to measure at rest. You have to have at the sitting and the upright position, then you get much better targets. So clearly, for now, those with a relatively high heart rate would be the ones that we indicated for this drug.
I want to expand on Cecilia's great observation that for the clinician who might anticipate using this one day, obviously not right now, it may be that the best way to use this is to respect the experience seen in the trial, that the benefit was seen most in the patients whose heart rate was greater than 77. For expediency's sake, if you've got a heart failure patient with a heart rate of 80 or greater already on a beta blocker, ACE or ARB, this may be an approach that should be considered.
And we talked just before we started to roll here about the subset of patients that have significant hypotension, and perhaps this is really something great for those patients who now have another treatment option, because that's the rate-limiting factor for me in my clinic when I see patients.
Well, that's what frustrates clinicians so much. They listen to those of us that do clinical trials, and we write these papers, and we get on a podium and say, titrate to the doses given in the trials, and the guys say, you're not seeing the patients I'm seeing. I just can't get there. Blood pressure is a limitation, or polypharmacy becomes too complicated. This is an acknowledgement that it is in fact difficult in a community setting to get the doses to what was seen in the clinical trial. And these were great heart failure people that were running this trial that were working very diligently to encourage the investigators to get the doses up. And with that kind of prompting, only 25% really were on the dose threshold seen in clinical trials. I think that's a real observation that reflects what happens in everyday practice. And so that's what makes the attractiveness of this approach so intriguing to us.
Well, it's just refreshing to have yet another option. And speaking of the differences in academics and clinical practice, we're going to talk about 2010 focused update of ESC guidelines on device therapy in heart failure. I noticed that the introduction, the very first page, it was almost an apology for stating that we previously have included patients that were enrolled, but now we're really going to treat patients that actually benefited in the study. So I thought that was really an outstanding statement, and they actually cited the MADIT CRT data and recommending now that CRT be limited to QRS duration of 150 milliseconds instead of 130. So, Cecilia, can you please comment on how you feel about now narrowing the number of patients that can actually receive CRT?
Well, I think it's important to give any therapy to the ones who actually indicate, and I think it's a good move actually to move beyond the inclusion criteria to who was actually receiving treatment. And it was very clear, both in the MADIT CRT trial and in the reverse trial, that patients with the QRS duration below 150 milliseconds did not derive a clear benefit. And therefore, in our mind, it's very clear and that they should not be given this therapy. I mean, it's not a therapy. It's just like any therapy. It's related to having lots of complications, and you must respect that, especially when you move from patients with very symptomatic to the milder heart failure states. Then you must know what you're doing. So I think this is a quite important step. And another step that was taken is that mortality was not affected either in the MADIT CRT or in the reverse, but still the substantial reduction in heart failure-related hospitalizations in both studies indicate that this is really about prevention, and that perhaps when follow-ups are prolonged, that there will also be an effect on total mortality. So I think there are different new steps here. First, you look at the patients who are actually included, then you move away from having total mortality affected and really recognizing that it's about prevention when you move to milder disease states.
So let me make a comment about the methodology, because I think this is a very important issue. In essence, the European guidelines are willing to make post hoc observations. We have to be very thoughtful about that, because when it's not the pre-specified threshold, we are always subject to statistical quirks, errors of overinterpretation or underinterpretation when we're depending so heavily on something that is an after-the-fact observation. Now, what gives me confidence that targeting a higher or longer QRS for the less ill patient is an appropriate step is that this has been replicated not just with reverse and with MADIT CRT, but also in CARE-HF and even in companion. The group that consistently demonstrates the greatest benefit appears to be the group with the wider QRS, the threshold being 150 milliseconds. So I'm very comfortable with that, only because we've seen it so many times. But it does make us pause a little bit and say, is this the right precedent that we're willing to look at what some would say the on-protocol group, or a group that is ostensibly a subgroup. That word subgroup has given those of us who spend a lot of time in clinical trials a lot of anxiety because it can be misleading. But let's go to another point you made, because in point of fact, I don't think this is going to narrow the patient population that will get CRT. It narrows the group that's eligible. I think it will expand the patient population getting CRT, because the ambivalence that clearly must exist in a community to explain the underutilization of CRT has to be assuaged somewhat now, given this tighter indication. And so hopefully there will be those practitioners that will say, clearly, many people believe that if you've got a QRS of 150 milliseconds or greater with low EF heart failure already on evidence-based therapy, you would benefit from cardiac resynchronization therapy. That might perhaps not revolutionize care, but it might be a breakthrough. We just spent a lot of time talking about the SHIFT-HF trial. Now, there are a number of reasons why device therapy may have been arbitrarily low, but honestly, CRT penetration was 1%. 1%. ICD penetration, 3 to 4%. So there clearly is an opportunity to do more with device therapy in heart failure.
So having said that, how do you think this is going to impact the economics of CRT therapy? I mean, so if it expands, really, in other words, the number of patients that can get it, is this going to be a good thing or a bad thing economically?
So let me take that head on, because the first assessment when you raise the question of cost or economics is, oh my goodness, those devices are how much per device? Can we afford that? But when we really do this, as we should, and go through a cost effectiveness analysis that looks at quality of adjusted life year that is established because of the therapy, that incorporates the complication rate, battery exchanges, lead issues, brings all of that to bear, and you still come up with a calculus that hits a threshold that is the accepted norm for the cost of life-altering or life-saving therapy, that changes the whole discussion about cost. And that threshold has been achieved with CRT both in North America and on the European continent based on published data. So we have to be a little bit more thoughtful and not just jump immediately on the cost of devices. I wish the devices cost less, but we have to put it in context.
Can I just add that we actually did that analysis in the reverse European patients and found that an ICER incremental cost effectiveness ratio per quality adjusted life years was on the range of 14,500 euros, which is nearly the same amount in US dollars, and which is totally acceptable in view of that in between 20 and 30,000 is the accepted level. And I know that the major CRT people are doing the same calculations, only that has not been presented as far as I know. So it will, in view of this, treatment will continue for many more years than CRT in severe heart failure. I'm sure that the cost effectiveness will be reached, and that perhaps in the range of 10-15 life years will be gained instead of in companion and carrier share much fewer.
Remember, the major influence here, and Cecilia said this up front, was reduction of hospitalizations. And in the United States, that's a big ticket item.
Absolutely. And I'm curious about something. In the U.S., we're just beginning to understand that left ventricular assist device implantation is actually pretty cost effective for these end-stage patients. So how difficult is it in your hospital to be referred for a VAD, LVAD?
Yeah, I think the major obstacle is actually that people don't know about what LVAD is or different types of VADs, and that there is destination therapy. So I think it's a major educational problem as regards to referring physicians, and people regard them as extremely expensive. But on the other hand is the shortage of donor heart, which is not going to diminish and probably just going to get worse. And the future, from my point of view, is really in those VADs and not in the increment of heart transplants. So really, us cardiologists, we need to teach the referring physicians more about that, and that we need to demonstrate also to the authorities that this is something that's cost effective, and the destination therapy is probably what's for the future.
I completely agree with Cecilia, but I'll add to that and say I think the real way to modify the cost equation in heart failure is to prevent the disease.
Absolutely.
Because with all the people that have the disease, we'll never be able to manage that burden unless we do something on the front side. But here's where I have to very politely take exception with my European peers and friends when I review the newly released ESC device therapy guidelines for heart failure. A left ventricular assist device carries a 2B indication in these new guidelines with a level of evidence that is less than top tier. Now, I certainly respect the adjudication deliberation process the ESC underwent to determine their guideline statement, but to be candid, 2B, at least in the same construct we use for the ACC-AHA, would say that benefit and risk are almost equivalent, and the most recent data referable to destination therapy using a left ventricular assist device make it very clear that risk is real, stroke especially, but benefit is profoundly impacted favorably so. So the 2B gives me a little bit of anxiety when I see that. And the lower grade of evidence when we have the trial rematch, in which I participated as an investigator, which was a very tough trial to do, but clearly demonstrated a signal that was statistically significantly in favor of left ventricular assist devices. And then for the most recent data points, using, again, a left ventricular assist device for destination therapy, and I had the privilege of sharing the DSMB for that study, those data are real. Those are two very difficult to do randomized controlled trials, active controls in the second one, medical therapy in the first one. But that's the bar, and I think it qualifies as a high level of evidence. So I respect the adjudication process that the Europeans went through, but I think we might have reached a different statement in the U.S.-based guidelines.
So is there anything at this meeting that you guys have heard that are going to change the way you practice in your heart failure management, Cecilia?
Well, we already mentioned the SHIP trial, and that's certainly going to attribute to what we can do in everyday care in the end. And there's also been some very interesting approaches which have not been validated through yet, such as the vagal stimulation, for example, that clearly modifies the need for heart failure hospitalization, also improves quality of life and exercise tolerance. We need to see more of that. There is the cardiac contractility modulation, which has not been fully explored yet. There is the neurostimulation, which was not really mentioned here, but which is being currently investigated. So there are lots of device approaches that might contribute on top of good drug therapy. Then there's the transvenous valves, the MitraClip approach, and that is certainly a big asset to therapy to the appropriate patients, provided that the technology is spread so that more doctors can master the techniques.
How about you, Clyde?
I agree with Cecilia. There's a lot of stuff here that's tantalizing, especially shift. But when the question is posed as what's likely to change everyday practice, the thing that has the most influence in everyday practice in today's world, guidelines. And what's very different about these guidelines is the new statements about cardiac resynchronization therapy in mild to moderate heart failure. That is not yet represented in the U.S.-based ACC-AHA guidelines, and now in these 2010 device-based focus update guidelines with ESC, there is a strong statement that says for the patient with mild to moderate heart failure, for the purposes of changing the natural history, there is a statement of indication now for cardiac resynchronization therapy, the proviso being a QRS greater than 150 milliseconds. And so we're beginning to capture this in guidelines, and that means that now that these guidelines are released, and I don't know where the regulatory space is in Europe with regards to device therapy, but if the regulatory space is harmonized with the guideline space, then ostensibly within days to weeks, practitioners will be respecting a different threshold with regards to the implantation of cardiac resynchronization therapy. That really is a different way of practicing right now.
And think about how we used to practice 20 years ago. I used to dread to go to the bedside of a patient with heart failure because I really didn't have a lot to offer. And now we have ACE inhibitors, we have devices, we have new drugs on the horizon. So it's really a very hopeful conversation that we're having today, and I really do appreciate both of you joining me for it.
Thank you so much, Melissa.
Thank you, and thanks for joining us for the Cardiology Show. We're at the ESC 2010 in Stockholm. Thank you.